We're in Mbale, Uganda, in October of 2011 with Dr. Sabiiti, a general practitioner, but with a different and broader definition of general practice than we're somewhat familiar with. And earlier today he told me of an interesting case. He does a lot of obstetrics work, and this, as you will see, was not a normal vaginal delivery. Dr. Sabiiti, can you tell us about it?
The pregnancy we're talking about was to a lady 42 years of age who was gravida 8 para 7, then and that was her 8th pregnancy by then. So she had abdominal pregnancy in brief, but before we came to that diagnosis, we got teased up until we decided to do a surgery on her, and that's how we came up with the diagnosis. Now, how did we come to it? This is the mother who conceived like any other person, and she did not know that her baby is somewhere else other than the uterus. As the baby grew, she was attending antenatal. Actually, she attended 5 of them before we did a C-section. Now, as she could check, unfortunately, the midwives who were carrying out her antenatal were not able to find out whether the baby is intrauterine or extrauterine. So when the mother came to term, you know, like the baby is grown up, has to get out of the mom. The mom could not go into labor, so it became a concern to the mother. So the mother decided to come to the hospital. Actually, not the hospital where I was working initially, another nearby hospital. So those people proposed a scar. Now, a sonography report showed that the baby is intrauterine, live, and is normal. Then the mother waited for the baby to come out in vain. 2 weeks, 3 weeks. Then the mother came to where I was working, and by then I was the ward manager. I was in charge of the maternity ward. So she came to me. I found her on the ward admitted. I read the sonography report. I decided to order a repeat of the ultrasound. So the repeat of the report of the ultrasound gave a report that intrauterine, the baby alive, liquamna is normal, everything normal. I said, okay, I've got you. Since it is post-mature now.
She's now like 40 weeks? Or?
She was actually 43.
43 weeks?
Yes. My concern was now the liquamna had reduced in amount, that it may be severe oligohydramnios, and maybe it may affect the baby. So I discussed with the mother, and we decided that we do an induction. Mm-hmm. So I tried the induction with misoprostol. I kept increasing the dose, no response. So I said, okay, I will combine catheter induction, Foley's catheter induction, and the misoprostol. Nothing. Well, what I have forgotten to tell you is that when I tried to score bishops, was lower than 6. Mm-hmm. That one, but I went ahead to give misoprostol. So when I looked at the cervix, feeling it now more critically, it felt like a non-pregnant cervix. I said, oh, okay. Now, I kept thinking overnight about this woman, and then I said, possibly it's something wrong. She's either not pregnant. What we are hearing as a fetal heart, possibly it is something else, maternal pulse or something, but it was actually a fetal heart. Yeah. So what we did was we discussed with the patient and for an operation. So accepted an operation, Getting in, I find a baby in the abdominal cavity. Now this baby, baby was encysted in a coating. Now this coating had attachment on the abdominal wall, on the uterus, part on the bladder, part on the rectum down there, and the sigmoid colon, and part of it was actually on small intestines, and a little bit on the liver. Anything around there had an adhesion, so it was like a frozen abdomen, if I may say.
Yeah.
Now, just opening like this, I made a classical incision, a longitudinal incision. Getting there, I just saw blood. Guess where I was? I was on the placenta, straight. Now, reaching the placenta, I had to be very fast, because now the baby's life may get compromised. So I had to get a little bit fast, sweep off the placenta, and tear off the cyst which was encysting the baby, and put the baby out so that the baby can breathe. After removing the baby, then of course the other coating, the other cyst collapsed. Said, what is this? So I started now peeling it all from the abdominal wall first, peeling it from the bladder, with taking care of the bladder carefully, peeling it off from some parts where it can be possible. But of course the teaching is that leave it alone.
Yeah.
But somehow you have also to consider other complications that may come in, intestinal obstruction and what have you, because those are adhesions that will mess up the abdomen. And so finally we decided to leave part of it, like on the part of the rectum. We had to slice the cyst, leave a piece, because it gives a patch behind there. What I forgot to tell you, this mother, some 6 months ago, prior the time she came, had a week with frank blood diarrhea. But it healed all of a sudden.
Yeah.
So I think possibly that's the time the placenta was getting firm, getting further infiltrating the surrounding parts. Because indeed we had the placenta was implanted just right across there. And then we closed the day.
But what about, there was a ureter issue?
The ureter?
Yeah.
Yeah, of course, the anatomy was messed up.
Yeah.
The anatomy we know, the anatomy we read in the class and whatever in the cadaver was not the cadaver, the anatomy found. So the ureter were, mixed up in the adhesive bands there. And then what I did was to tell my anesthetist to give Lasix or furosemide. So they got ballooned up. But on the left side,
so you could see the ureters.
I could see the right ureter, right from the kidney up to the bladder. At least much better than on the left. Now the one on the left had an adhesion. It was going through a very thick band. And in the process of adhesionolysis, the ureter of the left side got cut, got injured, completely detached, and I saw urine pouring. I remember my assistant telling me, my assistant, the one who was assisting on the surgery, was telling me, "Oh my goodness, we are killing you." I said, "No, don't worry." So I went ahead and removed, did whatever we could do, achieve hemostasis. Then I went on to plant. To pull a bit of the remaining ureter, and came to the bladder and planted it, just to make some kind of a trigon,
Yeah.
And sutured it very well, and put a catheter. I didn't have the catheters, the ureteric catheters we are trained, to use. I had to improvise with a neonatal catheter. Irene tube. So I put it there and connect to my urine bags. I catheterize both of them, the right and left, through the bladder.
Yep.
You had to make a defect on the bladder, then out of the wound. Then I put another catheter down via the urethra. Guess what? 10 days I was at it. She had improved. I removed the other catheters, 7 days. Then the other one, 14 days. And that was it.
Wow.
And the mother improved.
And how was the baby?
The baby had no problem. The baby was fine, was for 2.8 kilograms, a baby girl, pretty baby girl. And that's how it ended. Well, during the surgery, we could not spare because it was not very clear to identify the ovaries of the left.
Yeah.
But the ovary of the right was spared. We spared it. But the other side, we couldn't.
Was there a bleeding problem, or was that a different case?
It was. During the peeling off of some of these structures from delicate structures. I think that's the process, the process that actually caused the injury to the other side, and we had to just remove. We just had to, because we couldn't even know where it is.
No. Well, that's an incredible story. Yeah, that's probably the only one of those you've done.
Yeah, in the teaching, they tell us it is very hard for the baby to grow extrauterine to term, especially now post-term. You can imagine, we wonder how the baby was getting enough food, from that kind of... Yes.
Okay. Well, thank you very, very much. It's a fascinating story.
You're welcome.
Now, so there was one case, I thought it was this case, where you had bled, you put in packs and closed her a day later. Was that a different case?
It is the same case.
Oh, okay. Well, let's continue that. Oh, just describe that part of it.
Yes, I just ignored it. But of course, during the separation of the cyst from the other important structures, somehow we had bleeding, terrible bleeding. And I said, okay, my assistant, the instrument nurse, can you look for me a sterile mop? She brings a sterile mop that was large enough, breaks for me adrenaline, shock it, pack it there, introduce it. Actually, I even had to stitch it there.
Yeah.
Some, the abdominal wall sides. And closed the abdomen. Put the baby in the wall, in the mother to recovery from anesthesia. The mother recovered, and close to 24 hours, I went back and removed my mop, and now closed the game.
Incredible.
That was something we did, and actually it also helped me when I went back also to check on my ureter whether they actually okay, if there is oozing peritoneal fluid or blood getting into the bladder, but it was all pretty fine, and that was it.
Pretty amazing case. Thank you very, very much.